Hi, everybody. It's Professor Mulcahy, and I'm back to talk to you this week about populations at risk for healthcare disparities in global health and about nonviolence. That'll be sort of part two of the lecture. Populations at risk for health disparities used to be called, the lecture would have been called vulnerable populations, but let's go to the next slide and I'll discuss why that's problematic. I did talk to you about it in week one. But let's talk about what creates that vulnerability. Is it an inherent characteristic or is it a vulnerability that was created by structural problems? And this is a quote by Paul Farmer. There is an enormous difference between seeing people as the victims of innate shortcomings and seeing them as the victims of structural violence. Indeed, it is likely that the struggle for rights is undermined whenever the history of unequal chances and of oppression is erased or distorted. Or minimized, you could add to that. So we're using person-centered language. And we are describing people, yes, at the moment they are vulnerable because of structural inequity, but there is nothing inherently about those populations that is less healthy. It's not an innate characteristic. But let's get back to who is defined as at risk by United Nations. And they do still use the term vulnerable populations. You will get a link to that in the module. And there are some groups that they've identified. People of African descent all over the world, particularly descendants of the victims of the slave trade, but really all people of African descent everywhere in the world because of the enormous impact of colonization on the African continent. Indigenous people, for the same reason, in the Americas and in Australia. Roma, Sinti, and travelers is more regionalized to Europe, although you do see Roma in the United States. There's about 1 million people from that heritage in the United States. They've just sort of assimilated more into the culture than they have in Europe. In Europe, actually, I think it was in the Balkans, which is now Romania, it was legal to enslave the Roma people until about 1859. And that legacy has followed them. And if you're more interested in that, you will have a link to the United Nations website. I encourage you to look into it. When you see the discussion board prompt, you'll have that choice. Migrants are at risk for healthcare disparities, so they are considered vulnerable, even though the healthy migrant effect usually means that the healthiest people from a region are the ones that are able to access migration. They become more vulnerable when they get to their target country and they're victims of discrimination and they are denied rights. Along with that, we have refugees, asylum seekers, and internally displaced people, and we talked about those terms last week. And we have ethnic, racial, and linguistic minorities. Now, many of these groups overlap, so when you see the next slide that's on intersectionality, kind of think about that. People who are LGBTQIA+ all over the world are at risk for violence and for healthcare discrimination and for health disparities. Women, there is a quote somewhere in my reading. I want to say that it was Global Health by Richard Skolnick, where the most dangerous thing you can do in this world is to be born female, because it really puts you at risk for a lot of things. The gender inequities in our various societies is that strong. People living in extreme poverty are also at risk for many reasons. They don't have access to good food, clean water or sanitation at times, and they may live in communities that are marked by violence. So poverty is an extreme determinant of health. So other populations at risk, the United Nations doesn't have a separate category for them, but they have been identified in the literature. And, for obvious reasons, you could probably name 6 or 7 more if you thought about it, and you could go on from there. But children are a big group of people who have no agency for themselves. And when we get to the violence lecture and you see the statistics on how many children are impacted by violence, it will be appalling to you, I swear. So they are a population at risk. And also because of growth and development, anything that interrupts their normal health status has the potential to impact them throughout the lifespan if it hits them at that critical moment. Speaking of age, elderly people are also at higher risk for disparities in healthcare, both because of ageism and implicit bias, and sometimes because of other sociocultural um, conditions, and then, of course, the biology that's inherent in the aging process. People who are incarcerated, that picture in the middle or the picture at the lower left, people who are institutionalized in some way or another are at greater risk for health disparities. If you think back to the early days of the pandemic, um, there was really no control of those outbreaks once you were in prison, nowhere you could go. Violence is more common in those places, and people are marginalized because they're sort of forgotten about. They're not visible in everyday society to decision makers. People living with chronic illness, certain types that are highly stigmatized. For example, the picture on the bottom center is of a man with schizophrenia. And in addition to the burden of disease that's imposed on him by schizophrenia, which, if you remember my talk on DALYs, was really, really high, he's at risk for other health problems, diabetes, hypertension, and untreated conditions, and really maltreatment in the healthcare system because of the stigma of his condition. So there are some conditions, for example, obesity, that because providers may have implicit bias and have certain stereotypes of behaviors that go with those diseases. In some countries, we have HIV. The burden of the disease process itself is not as great as the burden imposed by the social stigma of having it. People with developmental disabilities for the same reason. And then this last picture here, all the way on the right, that is a rural community, and we know that people who live in rural or remote areas of the country or of the world are at greater risk because they don't have the access. And that is true, especially when the infrastructure, either the healthcare infrastructure or the road system or transportation is lacking. You hear about people who have to walk 6 hours to get to a healthcare center to access healthcare. So that is another burden that can be imposed on people. And now we're going to talk about intersectionality. You probably have already heard this term if you've had any DEI, like diversity, equity, inclusion training. And what it refers to is we all have these overlapping facets of our identities, right? Um, and you might identify as a sister and a friend and a piano player and other characteristics, things that are sort of things we're born with, that accident of birth. You're born male or female, or you're assigned male or female at birth. Um, you might align with an ethnicity, or you might identify as a person of color. You have linguistic differences. And when any of those identities is marginalized, and then they start to overlap, you have that additional burden. So there's this quote by Audre Lorde: "There is no such thing as a single issue struggle because we do not live single issue lives." And that is true. We all have many overlapping identities, but when more than one of them is marginalized or discriminated against, it increases the risk for health disparity. And that includes mental and physical health. So when you look at that picture, you really don't know anything about this individual. You don't know the name. You don't really know her or their gender identity. You don't know the nationality, really, but you make assumptions based on what you see. So based on what I see, I can assume that this person is female, that this person appears young, and with all the connotations that that has. I'm looking at the way she's dressed and making the assumption that she is Muslim. I might determine that she is a person of color, whether she herself identifies that way or not. And if I heard that person speak with an accent or in a different language, I might assume that she is a migrant or that they are a migrant. And in fact, those identities might not be accurate, or they might be, But the problem is that if I'm projecting my stereotypes and my implicit biases based on these identities, these visible identities, that person is now at risk for being treated differently because of them. And that can impact access to education. It can impact the way healthcare providers treat that person. It can impact economic opportunities, all different kinds of things. And then there's microaggressions that person might be exposed to. And all of those things have health implications. And particularly, if you had the whole picture, you would see that she's at a coffee shop and everything's in English. If she is a young Muslim female who is living in an Islamophobic culture that devalues young women and people of color, and those assumptions are being made over and over again, she might be the target of violence or maltreatment of some kind, and other types of discrimination that impact her health. So that is how intersectionality might impact health. You could take a whole course in that. This is a very, very superficial pass over all of these concepts. I'm giving you time to delve into it and give me some authentic self-expression, some things that you think and feel, impressions that you've made about them. I'm just going to discuss really briefly before we get into a couple of case studies. Levels of intervention. Most of you are familiar with the individual level of intervention. The documentary that I signed last week about Puertas de Salud in Philadelphia was targeting folks on an individual level. They were specifically targeting the migrant population in Philadelphia to mitigate their risk for health disparities. And they did that with health visits, health education, screenings, immunizations, treatment of healthcare issues. And they tried to remove the structural barriers to access by making themselves accessible during the hours that people could come, by making sure that everyone who worked there was fluent in Spanish or that there was interpretation provided, and that care was given in a culturally sensitive and appropriate way. And they made deep connections with those folks. And that all happened at an individual level to target a vulnerable, quote unquote, vulnerable group of people. Then we have interventions, and a lot of you posted about this at the population level. When you identified a country 2 weeks ago that had, and I told you to look at the burden of disease, the death and DALY rates, and the risk factors, and you decided that, say, somebody posted about Greece and the cigarette smoking. So you talked about having cigarette smoking campaigns. Other people talked about countries that had high rates of ischemic heart disease. And you talked about promoting fruits and vegetables in schools. And population level interventions are effective. Over time, you should see an increase in the overall health of an overall population in a given region. But when there are marginalized groups within the population, and there are structural barriers that prevent them from accessing the interventions, you can actually make the gap wider. And an example of this would be if you had a campaign in the schools to promote people consuming fruits and vegetables and reducing saturated fat and sodium and processed foods. And everybody understood the education. It was delivered very effectively. But about 1/3 of the students in that school could not access fruits and vegetables and whole grains and lean protein. What they can access comes from a corner convenience store that sells foods that are highly processed, high in saturated fat, trans fat, sugar, and salt. And so they might know better, but they can't do better. And that disparity actually gets wider as the people with access get better health, but the people without access can't access the education or can't benefit from that education. So that is one of the problems with population level intervention. If it doesn't specifically target the people most in need, it's going to create equality, but not equity. And then we can talk about targeting communities at risk. And this is what the World Health Organization is trying to do. But it is most successful when it is citizen led. It is led by the people in that group that's at higher risk. And they develop their own community and grow their own leadership because they know the problems their communities face much more intimately and in a much more nuanced way than an outsider ever will. So the job of people who have the resources to help, rather than going in and trying to save people, their job really should be to make sure that there's equitable distribution of resources, both financial and otherwise. And I'll talk about that. I think the next slide has a link to a podcast that I listened to that really clarified it for me. But what you want to do is approve the projects that are citizen-led, maybe partner in a sustainable way to help them grow their leadership. If they need people who can do research, help them learn how to write grants to get their own funding for it, help them acquire data collection systems, data storage systems, so that they can generate their own solutions because they'll really end up being better at it. And you'll get more community engagement when it's led by champions from within the community than from outsiders. So that's levels of intervention. And here is the podcast. So I'm not going to play it because it's about a half an hour more or less. I am providing you the link. It is optional, but it was really eye-opening. So it was two public health officers from Uganda, or from different parts of Africa. I think the lady on the left is from Uganda. And they were talking about the colonization of public health, which is a concept I kind of alluded to in week one. But what they were really talking about and what they really unpacked very well for me was that sometimes the most well-meaning people will create bigger disparities. So, for example, they talked about malaria. They were specialists. They said, who knows malaria better than Africans? We live with it. Our doctors treat it every day in the clinics. And yet you would get these people coming in from Europe and from North America who would have the solution. And to generate that solution, they went into the research because they wanted it to be evidence-based. But all of the research was also being generated by outsiders because that's where the grant funding was going for that research, because they belonged to universities that were wealthier. And she said it was almost as if they were trying to say that we were somehow inferior. We could not come up with our own solutions to malaria. And that was never the issue. The issue is there was maybe $20 million earmarked for a project, or $30 million earmarked for a project, and 2/3 of it went to these people from wealthier nations. They had high overhead, and most of it did not get to the boots on the ground people who were supposed to provide the interventions. And so they would end up with lesser resources, and it's very cost ineffective, and it was inefficient, and it wasn't enough. And so she talked about generating leadership from within. And she gave the other example. It was kind of humorous to me that during COVID, during the pandemic, they had to go to a summit in Germany to talk about contact tracing. And she said, Africans invented contact tracing to control Ebola outbreaks, and we were successful. And now we have to go and learn about it from somebody who's probably never done it and honestly does not have a great track record of controlling the outbreak of COVID in his own country. And so I started to see like the real irony. And even though I think most of it is very well intentioned, when you come in with a Western bias, the assumption is, oh, these people don't have what they need. I'm going to be there to give it to them. When really they need just to have resources equitably distributed so they can generate the solutions that they know are going to be effective. And that was sort of interesting to me. So when you are talking about intervening for groups who have been made vulnerable by structural inequity, think about letting the people who are most affected by that problem have the biggest voice, and just making sure that they have the resources they need to be able to do it. So that was interesting to me. You were certainly welcome to listen to that yourself. It's on the World Health Organization website. They have a podcast. There's a link. I'll make sure it makes it to the module. And then this last story I'm going to tell you, this is about healthcare in Tanzania. So we know that women are vulnerable. We know that infants are vulnerable. So this is another story of why things need to be led by citizens who are most impacted by the issues we're identifying. So Tanzania, for many years, had a culture and a history of home birth with traditional providers. And there was a high maternal mortality rate, and there was a high infant mortality rate. They didn't have access to the stuff, really, and they didn't have trained providers. So, public health officials with a Western bias came in and said, oh, no, we have to decrease home birth and increase birth with skilled attendants in government-run facilities. So they set up a bunch of these clinics all over Tanzania. And they promised women, there was a campaign, population-level campaign, go to the clinic. If you go to the clinic, it's free. The government pays for everything will be there for you. And then these clinics weren't funded. So there's a story in a book that I have, and I can provide you like the publication information for that. I really should be better about citing references. It's just that I read maybe 100 things before I do a lecture. And I want to get it out to you in a timely manner. But anyway, so there's a book about birth in 8 cultures. And it tells the story of a Tanzanian woman. She had babies at home with her traditional midwife and had no problem with that. But now the government wasn't going to let her register her children for birth certificates or get immunizations unless she did an attended birth in this clinic. So the story is that she gets to the clinic and waits outside the clinic for 8 hours before a midwife will see her. And she's in active labor the entire time. She finally gets in. They deliver the baby. It's very busy. The place is packed. She's only allowed to stay for, a little while. She goes home. She hemorrhages. They have to bring her back tied to the motorcycle because she almost fell off of it. Now, the whole time, that traditional birth attendant, that traditional midwife never left her side when she's sitting outside in labor and when she's coming back. It's the midwife who's coming in and advocating for her, this unskilled person who's trying to get her into this quote-unquote free clinic. And they get to her, and there's a delay in care because they're so swamped. They don't have enough staff. And then they can't find normal saline. And there's only 2 or 3 units of blood in the whole hospital. And the only fluid they have is D5W, which is not effective in a hemorrhage. And there's no surgeon and no anesthesiologist on staff. And that's the kind of thing. It's, okay, that's great. You thought of a solution, but it wasn't the solution that the people needed because they didn't have access to the equipment. And the midwives and the nurses in this clinic all gave these little speeches and said it's a very hard place to work because we know the right thing to do, but we don't have the stuff to do it. And so we'll send the families out to pharmacies to buy IV fluid or to buy medication. And then they think we're stealing from them because all the information that went out said that this was free. And that's where that cultural humility needs to come into play. It's not enough to say, these women need to give birth in a hospital with skilled attendants. If the skilled attendants don't have the equipment they need and the clinic isn't big enough to accommodate all the women that come there and you can't staff it because you don't have the educational infrastructure, you've created a bigger problem in a lot of ways. So that's just sort of the end of this video and, a wrap up of populations at risk for health disparities and why it's important to have citizen-led, community-led leadership and to decolonize public health. All right, so we will leave off there and pick up for nonviolence.